going to have our keynote session. And as we begin this session, let us just remember that patient-centered care is about seeing the whole person, their dignity, their choices, aspirations, and lived experiences, not simply their medical condition. And so this movement towards inclusive healthcare requires courageous voices, visionary leadership, and a commitment to ensure that people with disabilities are not merely recipients of care, but active partners in shaping the systems that serve them. So today we have the privilege of learning from one of the world's foremost thinkers and advocates in this field. It is now my distinct honor to introduce our keynote speaker, Professor Sir Thomas William Shakespeare, CBE FBA, one of the world's foremost scholars, bioethics, and champions of disability rights from the United Kingdom. Professor Shakespeare serves as the Professor of Disability Research at the London School of Hygiene and Tropical Medicine, and he is internationally renowned for his groundbreaking work in disability inclusion, rehabilitation, and health equity. As a former technical officer at the World Health Organization, he co-authored the landmark World Report on Disability, a publication that continues to shape policies and healthcare systems across the world. Drawing from both academic excellence and his own lived experience as a person with achondroplasia and a wheelchair user, Sir Thomas has dedicated his life to advancing dignity, accessibility, and equal opportunities for persons with disability. He is an acclaimed author, broadcaster, public intellectual, and a fellow of the British Academy, honored with a CBE for his outstanding contributions to disability research. So today we are very, very privileged to learn from a visionary whose work continues to inspire a more inclusive and equitable world. His keynote address today is Advocating Globally for Patient-Centered Care for Persons with Disability. Challenges us to rethink healthcare systems so that they truly honor the individual, their choices, and their humanity. Ladies and gentlemen, please join me in warmly welcoming Sir Thomas Shakespeare. Over to you, Sir Thomas.
You have been very kind, and I am hugely excited to be talking to so many people. And it's really a lifetime work for me. And I show you this slide about me, really to tell you that it was in 1989 that I started doing this work, a long time ago. And what was interesting was that I also had a father who had the same disability. He was a doctor, a medical doctor, a general practitioner in the UK, and my mother was a nurse. And age-old story, they met in a medical school, and they met at St George's. So when I came to Cambridge and I did my PhD about disability and sociological perspective, I was called upon to teach doctors about disability. And my father, who had himself studied medicine at Cambridge, was very excited on my behalf. I was very excited. And so I taught very much the same talk that I'm going to give now, perhaps with less data, but very much the same perspective. Then I worked a lot with geneticists, because you've been told I was a bioethicist. Well, I spent a lot of time talking about genetic screening. And a professor of clinical genetics at Newcastle called John Byrne said, well, I think you should come meet some of my people and some of the patients we work with. So I did. And we together founded the Policy, Ethics and Life Sciences Research Institute. And I was there for nearly 10 years. And then I went to WHO. And I went to WHO, and as soon as I started there, really, I had a spinal cord injury. So I was in Geneva, and I was obviously not well. And so I flew back to UK, and I got treatment there. And as soon as the treatment was over, I went back to WHO, and I was there for 5 years. And while I was there, we did this World Report on Disability, which was really important because I will talk about the Convention on the Rights of Persons with Disabilities. But the WHO World Bank World Report was the definitive guide to disability. It had chapters on health, and rehabilitation, and education, employment, and accessibility, and it was designed to show what could be done. Well, After that, I came back to UK, and guess where I came to? A medical school. And I'd worked at WHO for 5 years, and it's all about global health. I thought all that I've done in the UK up to this point has been about UK, about British people's health. But actually, UK is a very, very rich, privileged place. So I do work in Africa. We did a project called Bridging the Divide, which I did with Gross at UCL, and it was very much it was working in Uganda, Kenya, Sierra Leone, and Zambia, and I had been heard such messages about disability in Africa, like it was a real not a disaster, but real difficulty. It was there were so many problems, and everything I'd heard was about bad things. I thought, well, actually, all the disabled people I met from Africa through WHO have been very positive, inspiring people. So I deliberately went out to find successful people with disabilities in Africa. And I interviewed them. In fact, we together interviewed 105 people. And they were disabled people who told me about their lives, maybe shopkeepers or maybe as civil servants or teachers or whatever else, and how they had survived, not just survived, but also thrived, how they had enabled their children to go to university, and so forth. So there were success stories by any metric. And after that, in 2018, I came to London and I worked at the London School of Hygiene and Tropical Medicine, as you know. And here I have done, with my colleagues, a project called PENDA, which was with a dear colleague of mine called Hannah Cooper. PENDA is all about, look, let's find out if interventions to improve the lives of disabled people, the sort of things we see all over the world all the time, let's find out if they actually work. And the only way you can find out is to have a bunch of people who go through that intervention and a bunch of people who do not, and find out by the end of the intervention, are they better off? And so we've done 15 of those. So that's been really impressive. And through Succeed, we've also done what's called a randomized controlled trial in the same way, but it's particularly with people with psychosis in Zimbabwe, Sierra Leone, Malawi, and Nigeria. And we've been trying to find out if we can develop a peer support methodology which is really successful and good for people. And that's what we've been doing. So enough about me. You've heard too much about me. I mentioned before the 2006 Convention on the Rights of Persons with Disabilities. And I want to take that as the first point of my timeline. I've also mentioned the 2011 World Report on Disability, and I want to place that as the second point of my timeline. The third is what's called the Confidential Inquiry into Premature Deaths of People with Learning Difficulties, CIPOLD, CIPOLD. And this is a UK inquiry which found that most of these deaths, or a very high proportion of these deaths, were preventable. They were preventable because of better healthcare. If people had received what they needed, they would not have died early. So that was really important because it brought up this issue of people dying prematurely, and put a spotlight on that. So it's led to regular data-led inquiries into premature deaths. In 2019, my colleague Hannah Cooper and with other colleagues founded the Missing Billion. And that refers to the idea that there are a billion disabled people who are not getting the healthcare that they need. And so they've done a series of reports, which I'm quoting from, and they are a really important resource. And so if you Google Missing Billion, you will find out. You can Google any of this and find out. And finally, we have now the Lancet Commission on Disability and Health. And you know about the Lancet, the premier medical journal in the world. Well, they have a series of commissions when they think there's something important which needs the spotlight shone on it in a much bigger way. And again, Hannah Cooper has led this, and a number of us from all over the world have been contributing to investigating data about healthcare inequality, investigating the economics, what is being wasted and what could be better spent, and also investigating the political dimension. Why, if this is such a scandal, is it not better being solved? So that was my timeline. I would like to talk to you about some numbers because so far I have just been giving you words. Well, I'm going to give you a whole series of numbers, and that's why PowerPoint would have been better, but you will get the PowerPoint. So people with disabilities are 3 times as likely to have diabetes, twice as likely to have HIV/AIDS, twice as likely to be malnourished and die in childhood, 10 times as likely to be seriously ill as a child, 2 times as likely to be preterm or low birth weight, 50% more likely to be involved in stillbirths, twice as likely to have cardiovascular disease. And then, we can look particularly at women with disabilities. They're more likely to seek care, but they're less likely to get care that they need. 50% less likely in low middle income countries. They're less likely to be even registered at birth. They have lower knowledge about HIV prevention. They have a lower likelihood of contraceptive usage. They're less likely to get sexually transmitted infection screenings. They're less likely to seek antenatal care, attend antenatal class, and of having a skilled attendant at birth in a low middle income country. They have a lower likelihood of key cancer screenings such as mammograms and other pap tests in both high income countries and low income countries. So the numbers are really bad. Now, what are we going to do about it? I'm going to give you a series of developments which try to do something about that. The first I mentioned, the Convention on the Rights of Persons with Disabilities. And that came into force in 2008. It was drafted and accepted in 2006, and it has an article on health. So Article 25, it's about the highest attainable standard of health without discrimination. State parties, that is states which have signed up to the convention, shall take all appropriate means to ensure access for people with disabilities and health services that are gender sensitive, including rehabilitation. So, including sexual health. And I think the problem with sexual health and disability is that many times people think that disabled people don't have sex, don't have sexual needs, and it's really important to say, no, they're just like everybody else. Of course they do. So I'll go on to our well report, which will help understand some of these a bit better. But it's basically care of the highest quality. That's what we're calling for. So in the convention, it does say quite a lot about health. But in the well report on disability, we said a little bit more because we want to provide some of the data. So, for example, first of all, we made a distinction between their primary disability, for example, a person with spinal cord injury, right? They've broken a back either through road traffic accident or falling from a tree or whatever. So their primary disability, their secondary disability, so pressure sores, urinary tract infections. So those are, so for example, this week I've had a UTI. I would not have that if I was not a wheelchair user. So it's secondary to my primary disability. And then there are comorbidities which have nothing to do with your primary disability. So for example, people have a risk of HIV/AIDS or depression or whatever else, which is not to do with being, for example, in my case, a wheelchair user, a spinal cord injured person. So it's primary disability, secondary disability, and comorbidity. And we want everything to be well responded to by the healthcare system. We want to have regular checkups for people's primary disability. We want to have awareness that they're more likely to have secondary disability. And we also want them to be screened, I don't know, for let's say cancer or for anything else, which blood pressure, which everybody else would have. So that's the distinction that we made. What we did in the World Report on Disability is to look at the World Health Survey, which was something like 60,000 people around the world. And we were able to disaggregate disabled people from everybody else. And this is what we found. We found that people with disabilities are twice as likely to find healthcare provider skills or equipment inadequate to meet their needs. They're 3 times as likely to be denied care, and they're 4 times as likely to be treated badly. So the data is not good. There's a lot we have to work on, a lot we have to change. And of course, in many parts of the world, you have to pay for healthcare. In UK and some other countries, that you don't have to pay at the point of use. For example, when I got my antibiotics for a bladder infection, I did not have to pay for that. But in many places, I would. And that would, overall, looking at the World Health Survey, disabled people have a 50% higher risk of catastrophic health expenditure. Now, what is catastrophic health expenditure? It sounds bad, doesn't it? Well, that's because it is. It's expenditure which drives you into poverty. So if you're living in a poor country or America without healthcare insurance and you have a disease or disability, you are 50% more likely to be pushed into poverty. And I think that's a really bad statistic. So I mentioned SIPOLD above, the confidential inquiry. And at the time I mentioned it, I thought, well, I need some more data. I need to be able to quote from it. So let me tell you what SIPOLD in 2010 found. The confidential inquiry found nearly a quarter of people with learning disabilities in their study were younger than 50 years when they died, with women dying on average at a younger age than men. Now, I'm 60. I've got many friends who are 60 or above. None of them, or a quarter of them, would not exist if they had learning difficulties. They would have died, which is a horrible thought. SIPOLD also reported that up to a third, 1 in 3, of the deaths of people with learning disabilities were from causes of death amenable to good quality healthcare, so that they could have been addressed by better healthcare provision. And it led to a national mortality review program for people with learning disabilities. And so, as I said at the time I mentioned it, it really drew people's attention to the problem. So there's been more data and it just reveals problems. So let me move on. So what are the barriers to disabled people getting equal healthcare to everybody else? Well, we can talk about the near patient barriers, right? So the near patient barriers, I would say, include, I'm sure there are more, but include travel. So can you travel to the clinic? For example, is there a clinic? Is it accessible, the transport? Does it cost too much? So is there a bus? Is there a train? Is there a taxi, which you can get into with your disability at a price you can afford? So there's that travel. That's the first thing. Secondly, and a huge area, the attitude of medical staff when you turn up. Because you're just another patient, aren't you? You want to investigate or to treat a problem. But the problem is, if you have a disability, if you're a patient with disability, you have the danger of diagnostic overshadowing. So they might explain all your healthcare issues with the fact that, she's got psychosis or he's got Parkinson's or whatever, when it might be nothing to do with that. So diagnostic overshadowing is a major problem, explaining everything with reference to a primary disability. A second major problem is infantilization. So when you're treated as if you can't speak for yourself, when perhaps your friend or family member is asked questions, not you, when the language is less appropriate for an adult. So I think that is a major problem for many people in many encounters. And thirdly, what my friend Caroline Bowditch said to me, or said to the people she was training, she was saying, the problem is that many medical staff ask want to know, not need to know questions. So we want to have need to know questions. So questions that will make a difference to understanding our healthcare or solving our healthcare problem. We do not want to know questions because those are intrusive and inappropriate, and they should not be in the encounter. I remember when I was at WHO, I met a friend of mine, Suzanne. She was involved in women's health worldwide. And she told me the story of a woman from Mali. And she was going to the hospital because she was heavily pregnant and she was about to give birth. And she was in a wheelchair. So she turned up at the reception of the hospital, and before she got any medical attention, which obviously somebody in labour would desperately want, they laughed at her. They said, "How did you get pregnant? You're not meant to be pregnant. What was that about?" So they found it very funny that she was about to give birth. She just found it very urgent. She needed medical attention. So there's all those attitudes which are potentially an issue or a problem. Another question is accessibility of the clinic. So can people even get into the clinic? And remembering that it's not just about a ramp or a lift or whatever at the entrance, it's also about, are there couches which you can transfer onto? Are there machines which can measure your whatever it is, your X-ray, or can you transfer easily onto? So all of those access questions are very relevant. But of course, access is not just about physical access. It's also about things like signage. For people with low vision, is it very clear where you're meant to go? For people who are deaf, is it clear that there is BSL, there's interpretation, or whatever your language is? I was thinking of British Sign Language, but of course, American Sign Language or whatever else, Auslan or whatever else, would be much more relevant in other parts of the world. Is there signage available? Can you book that? When you get your package of medication, is there Braille on the packaging? Because, of course, if you have a visual impairment, you might not be able to tell the difference. So Braille is absolutely essential. And I remember I used to do it when I was at Norwich Medical School. I used to do a session for training doctors about working with disabled people. And a friend of mine called Matt came to talk to the folk about being deaf and a BSL user. And he talked about his appointment in audiology. And of course, if you have a hearing issue, audiology is the place for you. So he turned up and he had a time for his appointment, but it never came. Or rather, it came and went. Because do you know how they announced the meeting, the appointments in the audiology clinic? They just shouted the names. So they would say, Matt, or whatever his surname was, Matt. And of course, he was deaf. So he did not hear. So he went home. And that was a waste of time, both for him and for the health service. And so you'd think that people would get that possibly right. Some people, of course, find waiting impossible. We're all used to waiting for healthcare, but some people cannot wait. So it's really important for their time to be honoured and them to be able to get in whenever it is. And of course, some people need longer consultations. So, for example, they may take longer to explain their issues, or they may have more issues. So I think that innovative queuing or non-queuing for people, a regular monthly clinic for people with intellectual disability, for example, an immediate drop-in service for people with autism or other impairments. Those sorts of things that are very innovative, imaginative ways of redesigning healthcare so it can be more accessible to people. So yeah, very, very important. As well as those near patient factors, there are wider factors which are relevant. I mean, access to healthcare is an issue for everyone. So in your society, can everybody get the healthcare they want? Because if you have poor access, then of course you will be disadvantaged. Um, Also, stigma. Is there an immense amount of stigma attached to disability? Or attached to, for example, psychosis, or attached to epilepsy, or other things? And that includes self-stigma. So even if nobody actually is going to buy you, you may think that you cannot ask for this help because it's so stigmatized, it's so embarrassing, it's so awkward, and it's much more difficult for you. Thirdly, there's health insurance, public or private health insurance. Are you covered? Is that existing? Will it be paid for? Can you get free healthcare, at least at the point of use? Really important. Social protection, the idea that you have a decent standard of living, you're not poor, and wider public and private infrastructure. So can you get into houses and homes? So, for example, when I had spinal cord injury, I spent 10 weeks in a rehabilitation in a hospital for rehabilitation of people with spinal cord injury, and there I got to know half a dozen people who were also one had fallen off a horse, one had fallen off a push bike, one had been crushed, being a quad bike racer. So yeah, they were the people that I got to know. But when it was time to go home, when we'd learned everything we needed to learn, I was the only one who was able to go home straightforwardly because my home was wheelchair accessible and theirs was not. So they had to wait to, I don't know, build an annex or move house or otherwise get ramps or some solution. It's much more difficult. So lots of near patient and wider factors that make healthcare barriers, make healthcare more difficult to get hold of. And I would say this is important also because healthcare is vital to the other rights that disabled people have. And if we want to look at rights, as I said, we should look at the Convention on the Rights of Persons with Disabilities. And there, any of these articles. So, for example, Article 19 is about living independently and being included in the community. Well, that might be much more difficult if your healthcare needs are not met. Personal mobility, Article 20. Well, if you have pressure sores or if you have not got a wheelchair or other mobility device, of course, you're much less likely to be able to enjoy that. And the awful statistic is that only 15% of people who need a wheelchair have it. So worldwide, there's a massive shortage of assistive technology. We can look at the right to education, Article 24. Well, of course, if you haven't got a wheelchair or splints or a reader or whatever, or a computer with JAWS software, whatever you need, you're not going to be able to learn. And so that is, an education is such a pivotal thing. So healthcare as a way into education is very important. And of course, the right to work both when I started my current job, I had to get a mobility device in order to get to work. So I have a wheelchair, that's fine, but I needed something to push that wheelchair so that I didn't have to wheel all over London and have the sore arms, the rotator cuff injuries that would result. And if I don't work, or anybody doesn't work, they don't necessarily have a good standard of living. So you can see why, if you can't, say, work in the fields and grow your food, or you can't make things sell, or you can't go to work and all the rest of it, you're going to be less likely to have money. You're going to be less likely to be able to look after your family. And finally, what do we do the rest of the time? Cultural life, recreation, leisure, sport. None of those are possible without healthcare. So you could really see any of those articles of the convention would be that healthcare is a gateway to all of those. Really important. So I will conclude fairly soon, I think, and then we can have a discussion. So the goal of our efforts to improve is health equity. So it's not quality. We're not saying everybody has to be the same. It's equity. And equity means that we eliminate the social barriers to good health. So anything that we can do to make sure that disabled people have access to the same standard healthcare of other people is our goal. Because, we're not saying that people have to be better. We're saying they have to be as good as. And often, as I've shown you from the data, they are not. So if we want to say, why is this important? I mean, it may stand a reason for you. You're here after all, you must think it's important. But there are three, I'm going to say there are three really strong arguments which we can make for that. The first is from human rights. So right to the US Declaration of Human Rights, health is in there. And it's been in all the articles, all the treaties and instruments there. So, and obviously I talked to you about the Convention on the Rights of Persons with Disabilities. So we cannot fulfill our human rights without health equity for disabled people. That's really important. Secondly, there's an argument from social development. So we look at the world and we want poorer countries to develop. We want them to be places of where people can flourish. We recognize that they are on the road, but we hope they will get there. Now, they won't get there with disabled people being left behind. And if you think about all of those development goals, sustainable development goals, millennium development goals, whatever they might be, all those targets, we need to include disabled people in those. Because, for example, if we want everybody to go to school, that's great, but it has to include disabled people. So that's one. If we want every woman to have healthcare, safety, security, that has to include all the women with disabilities and so forth. If we want to have an end to climate injustice, then people with disabilities have to have access to safe systems for emergencies and so forth. So lots of social development arguments only make sense if you include persons with disabilities among everybody else. And in fact, if you make sure that they are also included, because you might think you solved the problem, but you haven't yet, probably. And third and finally, that is to say, there's a huge waste of human capital. That there are so many people who could be productive, who could contribute, who are wasted human beings in terms of what they could do. If only you overcame the barriers which stand in their way. So if you gave them, they were able to get good healthcare, if they're able to get good assistive devices, if they're able to get good physiotherapy, good pain management, all those other things which I'm very glad to see you're dealing with in this great summit on inclusive health. If you're able to get access to all of those, then I think you would have less wasted money. And more to the point, you'd have lots of people able to do what you need as a society to develop and thrive. So, for example, they would not need to be looked after. At the moment, there's more carers, but we could say, look, you don't have to care. I'm fine. I'm independent. You go to work. Or their children could be productive in looking after the children or whatever it might be. But the point is that instead of being a waste of money, they would be an asset, a huge asset to the economy. And of course, the final argument is one from, I would say it's from morality. It's about suffering, and it's about reducing suffering, and it's about ensuring that people get the treatment that they need in order that they can be the people that they have the potential to be. And too many folk uh, who could achieve such a lot are held back by the way that we fail them. So that's my concluding thoughts, and I'd very much I will send my PowerPoint so you can have a copy of this, but I'd very much like to see any questions. So if you, I think if you put up your hand digitally, you're welcome to ask me a question, and then we can carry on with the discussion. So over to you.
Wow. I'm still mesmerized by everything you have said. I know I had some questions, but I feel you've already answered them, and we really appreciate that very, very powerful opening keynote speech. Thank you so much for that profound and thought-provoking address. Those insights,
Thank you, sir.
yeah, they've just reminded us a lot of things that we sometimes ignore or assume. And I'm really, really glad to hear in your last comment where you emphasize that we having to include persons with disability, especially in social development,
I
in the
think
human, yeah.
I think
That's,
hearing from disabled people in all of the sectors, whether it's social development or whatever, in the church, in the temple, in the mosque, in the home, in the village, disabled people are wise, not always, but often. They certainly have the same access to wisdom as everybody else, if not more. And therefore, we should try and make sure we learn from. And I
yeah,
think that's really interesting, the idea that we should learn from disabled people, because
yeah,
disabled people are used to being treated as if they have nothing to say, as if they have no opinion, as if they should not be consulted. And yet, we all know so many disabled people who, whatever their profession, do contribute massively to their world. And that's whom we must support, honor, include, and answer when they have things to say. So,
yeah.
any questions?
Anybody with a question? I saw somebody had asked a question earlier. What did she say? Rose Waringa, is there an age of consent to sex to a girl with disability above 18 years when it comes to legal rights? I imagine
Well, I
that
think
applies to
Yeah,
countries.
I think generally speaking, the age of consent is the same for people with and without disabilities.
Mm,
However, there is an important consideration, which is, does the person have capacity? Are they able to understand, to remember, to recall, and to repeat, and to answer? And if they do not have capacity, and some unfortunately people do not, then there is illegal in most jurisdictions to have sex with them. So it's less about their age, but also, so for example, if some lady was inebriated, if she was drunk, then if you had sex with her when she was drunk, she would not really have said yes. She would be out of her mind, whether it's
mm,
drink or drugs, and therefore it would be rape. And the same applies to many, not all, but many folk with issues of capacity. So I think they would have to decide. And the fact is that sexual violence against disabled people is high. Violence against disabled people is high. And we need
mm.
to understand that and to respond to it. So thank you very much for the question.
Yeah, so John says, absolutely inspiring presentation. Sir Thomas, would the LGBTQ community be considered under the disability framework?
No, well, I mean, being lesbian, gay, bisexual, transgender is not a disability, of course. But certainly there are lots and lots of persons with disabilities who are LGBTQ. And we must, so for example, we must be aware of that. So we must not slip into heterosexist or even homophobic ideas that they're not welcome or that that's not possible or that's not what people do. So I think I would hope we're able to give advice to people whether or not their partner is the same gender or a different gender. Um,
Yeah,
and we need to make sure that we are aware of people's other identities. I think they're not disabled because of LGBTQ, but they
yeah,
might be, as it were, it might make their life more complicated and it might make their difficulty in finding a healthcare provider more complicated. So, for example, many disabled people in UK would rely upon a carer. They would rely upon somebody to come to the house and maybe help them out of bed or maybe help them to food or maybe whatever. That's what carers do. Now, if somebody is, carers are often not very well paid, often they're often migrants. So they may, some, not all, some may have conservative attitudes. So imagine you're a gay man or a lesbian woman or whatever, you have a same-sex partner, but you also have a carer. And imagine if they start preaching to you that this is wrong, sinful, you're going to go to hell, or whatever else it might be, because of their Christian, Muslim, or other background. I don't think that'd be acceptable. I think yeah, you should be able to get a carer who does not impose their morality on you. And I'm afraid, this is not a made-up example. I'm thinking of a real example. And the same, I think, should be, lots of healthcare workers are inspired by their faith. And I applaud that and I welcome that. And they're very welcome. And thank goodness for them. However, they should not impose their morality when it comes to it on their patients. And most 99.9% do not, but occasionally they do, and I believe that is wrong.
well said. I have a question for you. So, the World Report on Disability has transformed global conversations on inclusion, like you've mentioned some of it. 15 years later, what progress are you most encouraged by, and where do you believe we are still falling short?
Ah, it's difficult, isn't it? It's more than 15 years later because we published it in 2011. So the Well Report is now more than 20 years old. It's a very old document. So we need to update it, and it is being updated. What it encourages me, I think the improvements in access. So when I first started traveling around the world working for WHO, yeah, it was not easy to get, for example, onto planes. So to get around buildings or hotels or meetings or whatever, it's not easy. Well, now it is easier. There's more awareness. There's more inclusion. So I really welcome that. I also welcome the fact that many brilliant disabled people are shown a way. They're showing what can be done. So what I didn't mention in my talk was the disabled people's organizations. So, for example, there is IDA, the International Disability Alliance, which is an alliance of disabled people's organizations, which may be there for deaf people or people who have physical impairments or people who have sensory impairments, hearing or sight, people who have intellectual impairments, and people who are survivors of the mental health system. So IDA is really important because it brings together the voice of disabled people worldwide. And there will be groups in all these countries. And I think it's really important to find a group and work with them and make sure that the innovations you're developing are appropriate because we all know about well-meaning but inappropriate interventions. And I love Turkey, and I don't want to be negative about Turkey, but let me tell you one thing. I remember when I was about 10 years ago or so, there was a big drive to make Turkey more accessible, which I think is great. I don't have a problem with it. I think it's great, and it's probably got a lot better since. But at that time, what they did was they said, "Oh, we've got ramps everywhere." And I went and I found out that what they'd done is they'd taken a flight of steps and they'd put concrete over it. So it was the same pitch as the steps, but it was now smooth. It was able to be traversed. Well, it was able to be traversed if you were Goliath, if you had immense strength, because, of course, the steps are far too steep for a wheelchair user to traverse up steps. It's true that with a push you may be like it, but it did not fill me with confidence. And that's not the only place. There's lots of places in the world which have tried to help but have not succeeded. And I think the answer is to listen to disabled people. And if you listen, you'll find out what they need and you'll be able to provide or negotiate to provide what they want.
So there's a question here from John. Is there any estimate of the disability burden in the global south relative to the overall disability burden?
Well, I mean, we know that 4/5 of disabled people live in the global south. So whether we say it's 1 billion, 2 billion, whatever, 4/5 of those live in the global south. But I'm not sure that that is a surprise to us because 4/5 of the world's population live in the global south. So I don't think that is, remarkable. We might say that people in the global south don't necessarily live into old age. I mean, some do, thank God, but many people die prematurely. All people, not just disabled people. So what we might say is that in the global south, there is a high incidence of disability, but the prevalence is not necessarily any higher than in the global north. What I'm saying is that many people are born with disability, but maybe not surviving into old age. And therefore, the numbers of disabled people are not necessarily higher. So, yeah, it is more of a problem. I've been to, as I say, I've been to lots of countries.
Yeah.
One of the things we've been trying to do is to improve availability of assistive technology, of wheelchairs and so forth. So, for example, we were working in Cameroon, and I'm not sure if there's anybody here from Cameroon, but we were providing wheelchairs to people. And I think that's great. Wherever you are, the wheelchair is very good. It enables you to move around your home and your community. But the problem is in Cameroon, it's a very, very hilly place, certainly where we were working. So whereas in, say, Australia, a wheelchair would have enabled you on a tarmac road to go everywhere, in Cameroon, it didn't enable you to go very far at all. So I think, there are issues which we can't do anything about, which is about the terrain, about the heat, about the sand, and other factors which make life much more difficult. So yeah.
So a question from Robert Hill. 2 weeks ago, an X-ray facility in Central Florida refused to take my X-rays because they declared me non-ambulatory, even though just over a year ago they had taken my X-rays in my wheelchair. How are they allowed to refuse me based on an internal policy?
Well, you're in Florida, that's covered by the Americans with Disabilities Act, and I would say that was illegal. I think they violated their rights as an American citizen, and I hope that somebody takes up that case pro bono and says to them, you can't just discriminate against this gentleman when you took, you've got a good case there. So I hope that somebody in Florida hears this and takes it up.
Yeah. So a question from one of our members, Mark Stoddart. In the UK, the number of people claiming disability benefits has risen significantly. With working age disability benefits are forecast to reach £25 billion by 2027-28. Why do you believe there's such a significant increase?
I don't know. To be honest, I don't know. We're studying this at the moment. We're looking at social care and what's called PIP, which is the benefit. and we need to find out why there's been this increase. But I think increases often reflect wider economic issues. So, for example, in the years when Thatcher was Prime Minister, disability benefit rolls rose. Why did they rise? Because many men in their, say, 50s were being made redundant, or their factories closing, or there's no coal mine, and therefore, rather than putting them onto the unemployment register, they were likely never to get a job, so they're put onto the disability register for benefits that way. So I don't necessarily think, for example, that it reflects increase. Having said that, we are all aging societies. So Britain is the same as anywhere else, or more so. So it may be that more people are coming to that category and claiming that benefit. But I think, yes, you're right, it should be investigated. And the practices which are channeling people towards that as an option need to be, I think, because I think disabled people should be productive, can be productive. So anything that promotes that is good.
Somebody just made a comment here. Ramu Kaladi says, why are we calling it a disability burden? I thought we are trying to remove the stigma of disability as a burden.
Well, I mean, yes, we are trying to destigmatize disability, but I mean, I can tell you, I have had a UTI week. It was a real hassle. So I think we have to do two things. We have to say what people with disabilities are valid, viable, welcome. We must support and include people with disabilities at all times. But we need also to have space to say disability is sometimes a pain, if you'll forgive my language, in the butt. It's something you can live without. And so I think I think burden of disability is a very stigmatizing term. I'm sure it's not meant in that way. But the fact is that having a disability is a problem. We teach people to look both ways while they cross the road. There was a wonderful sticker that I got from South Africa, from the Quad Para Association of South Africa, and it said just this. It said, "Buckle up," meaning seatbelt, because we don't want new members. So they were involved in the prevention efforts. So I do think prevention is good, and at the same time, we need to honour and include all persons with disabilities, because we owe it to people to include them, not to prevent them.
Yeah. So I'm just thinking, for me, this is my last question because I can't see any other questions here. But if every Rotary Club in the world committed to one action to advance disability inclusion over the next year, what should that action be and why? Majority of us here are Rotarians.
Yes, I know. And Rotary is so powerful and so welcome as a friend. I think the Rotarians are often very prominent in their local communities, and they have so much influence. And I would think that all these communities that you come from throughout the world, can we talk to our council members? Can we talk to our mayor? Say, look, we want our city, our town, our village to be a model of inclusion. We want to make sure that we are known for where disabled people are welcome and where the terrain or the facilities are accessible to them. I think Rotary has so much influence through ordinary communities. So I would say that nothing special, nothing exciting. Just do what you do and always remember persons with disabilities.
Thank you so much. Thank you for inspiring us. Thank you for just giving us these thought-provoking ideas in our heads. It's nice to listen to somebody like you. You're one person whose voice is very powerful, but I know all of us can do something. Yeah.
It's a great privilege to be here. I will send my PowerPoint to Ken Masson, and I hope he'll be able to circulate it. I'm sorry, my fault on not being able to show it to you today. I assure you there weren't any pretty pictures, so you didn't miss any content. You got everything I would have said. All right, thank you so much, and good luck in your work.
Thank you so much, and have a lovely day.